My name's John. I work at Mid Yorkshire NHS Teaching Trust. I've been a nurse for 25 years, so I'm up for my 25-year service this year. My clinical background was 18 years in spinal injuries. I had a short stint in the discharge team, and then I've been 6 years in the quality team that I've been in. And I've run a programme around the screening tool within the trust. So, question I have for everybody here, and I just want you to think about this, is do you think the sepsis screening tool is important? Is it something that you feel you should use? Heard some yeses, that's really good. Because this was the first question that we had. So when I came into post, our inpatient screening use was between 0 and 4%. That's what it was, you know. And a lot of trusts report the same sort of things. So we were looking at the reasons why that was happening. And some of the things that we found out was our nursing staff would say, this is a medical job. Medical staff would say, I don't need a screening tool to indicate that someone has sepsis. And as a result, no one was really doing that. So we had a honest conversation, and we said, do we want to promote the use of the sepsis screening tool? And if this is a journey you are embarking on, you need to have senior leadership behind you when you make that decision. Now, I've got one of my senior nurses right at the back there. Lisa, put your hand up. I can see you hiding. So Lisa has backed our programme absolutely massively, and so have some of the other senior leaders within our trust. And you really do need that backup, because otherwise you'll get into the conversation of, yeah, but we did the treatment. And I say, well, do you want the sepsis screening tool or do you not want it? And we got a lot of backing for that. So our starting point, 0 to 4% was routinely, that's where we were. Antibiotic was only administered in about 50% of the time. That's where we were. And we didn't hide from that fact. We just say, right, well, this is where we are. We have to acknowledge where we are so that we can move forward. Nursing staff often said they were unaware of the screening process and who that responsibility sat with. And then the medical teams didn't engage with it. And one of the things they said to us was, you need to make your screening tool electronic. We won't use it while it's on paper. So we did that. We turned it on electronic. And we said, right, there you go. This has got to work now because this is what you said. And guess what? It made no difference whatsoever. So we rolled out a bit of a training program, and I spent a lot of time doing training programs, and I went in and went, okay, we've done the training, we've gone around all these wards, we've done the drop-in sessions, we've given the doctors what they wanted, surely this will fix it. It didn't. So then we kind of, oh God, I can't see that, that's too small. So we did what we said, the background work before we moved on to the quality improvement programme. So we had that senior conversation. So we had the workshop, and we all said, right, do we want to use the sepsis screening tool? And the unanimous result was yes, we do. And we're like, okay, we can't move away from that then. This is the track that we are going down. Then we advanced the electronic and we activated the screening tool to be turned on. And it was quite really ironic because our EPR system, the provider we had it from, wasn't even using the screening tool that they produced. So we were the first ones to turn it on, and which I thought was quite weird when we did that. But then we did a poll with nursing staff, and we said, how do you want to use the screening tool? How do you think the screening tool should work? And what's going to make it better for you? And then we also said, who is best to use the screening tool? So we had that conversation. So we decided it was going to be the nursing staff that were going to activate the screening tool in patients. And we said that because primarily our screening tool is linked to our observation scores, and that's where it was sat with. So we went, this means a good thing for our nursing staff to use the screening tool. So that was the first thing that we decided on. Does that mean doctors shouldn't use the screening tool? They don't need to use the screening tool? Absolutely not. They should still use the screening tool as well if they feel the patient has sepsis. The second thing we looked at was developing the education packages. So we said to ourselves, but why do our nursing staff, or why do our staff not do what we want them to do when we're talking around sepsis? And so very naively, I said, have we told them what we want them to do? No, but the nurses. I mean, if we don't tell staff what we want them to do, then they're not going to do it. Okay, well, we need to put the education package. And then I went, oh, I realise what I've done now. So hence the education package that we have embarked on. So all of our staff that come into the organisation, they will have their induction training, and part of that induction training, they will have a sepsis element. And every member of the staff trust gets that at a different level. We also then developed core competencies, and the core competency, we had it in a booklet, and again it's written for the different appropriate staff levels, and they get those core competencies signed off when they get onto the ward. And then we also developed an e-learning package. So the e-learning package, we currently, in our trust, it runs every 3 years. So every 3 years, registered nurses do an update of that e-learning package that we do. So what we've done is we've brought in a very good education program awareness around sepsis. And then we've spread this out then into when our new doctors come and join us, they get their version of their training for sepsis around there. And this year we actually tagged on blood cultures and put that in there because we identified that blood culture contamination was at 7%. So we thought, well, let's kill two birds with one stone, and we put that in there as well. So we put that in, and what we were trying to do was change the culture, you know, and I'm very much wanting to change the culture around sepsis. I believe it's everybody's responsibility. Everyone plays a part, no matter what role they do within the NHS. So the Quality Improvement Programme, it ran for 5 weeks on every ward. Now, I spoke to one matron, and she said, 5 weeks is a very long time. Why does it have to be 5 weeks? And it was. I said, just bear with me, because we trialled shorter versions, and it didn't embed in the wards. So we needed the 5-week programme. So we had a 5-week programme that allowed allotted time of 30 hours, for teaching time over the 5 weeks. So I would go in and I would do a teaching session with all of the staff, and we aimed to get all of the staff in to those sessions. And sometimes they were a one-to-one because that's all the staff the ward could release. Sometimes it was 3 or 4, and sometimes we had bigger sessions. And so we give what we wanted staff to do, and we had a presentation for that. As that moved forward, we then also developed a narrated version, because we had staff who were permanently on nights who I wouldn't see, or only worked weekends and different shift patterns. So we brought that in, so they had a backup of that. When we had the programme then consisted of the 3 phases. It was the face-to-face teaching session, and then the second one was the monitoring phase, and they worked at the same time. And then the third one was the self-monitoring phase. So what we did was we brought in the resource folder. So the resource folder was electronic, and it was also a manual copy, and it had the how-to guidelines. So if people didn't know how to use the screening tool, it would tell them step by step. We had posters in there. We had little reminders for staff. We had the business cards, Sepsis 6 business cards that we used, and we give out to all of the staff. And then I would go in, the ward manager would nominate who their champion was going to be. We had a contract, so the ward and myself had the contract, like, this is what you can expect from me, and this is what we expect from you to do. And we all signed off that, and we agreed on that. And that was to get the buy-in. And if you had the buy-in, then the program rolled out really, really quickly, and you could see the tangible results. So that's kind of what we did. The monitoring phase was something that I did in the background. So every morning I'd come in, have a cup of tea, and then I would start looking at our EPR record, and I'd look at all of the patients' observation scores on that ward 24/7, 7 days a week. And we're looking for, had there been a news trigger? If there was a news trigger, then we would document it. I would document it on the quality improvement sheet, and then I would look back to see if we'd done that sepsis screening tool. If the screening tool was done, we'd mark it onto the sheet that it was done. If it wasn't done, then we would send an email to that member of staff, copying the sepsis champion and the ward manager, and to say that we hadn't done that. Now, this was not a telling off email, although I did get some people saying I had told them off, but it was not a telling off email. It was just to reinforce, this is what we want you to do, and this is why we want you to do it. So we give the reasons for that. So we had that for registered nurses, and also if we had a healthcare assistant who hadn't had the countersign, because our observation requires a countersign if they have a news of 5 or above, 3 in 1 parameter, they're locked out, and they have to get an RN to sign the observations to say that something is wrong. And that's the point where we ask staff to do the sepsis screening tool. We also ask staff as well about repeating the screening tool. Where do you want to do this? And what our nursing staff said was, we want to do the screening tool every day for our shift. Now, I like that approach because originally our screening tool was 72 hours and then you would repeat it. And people were saying, do I need to do it? Did John do it? No, I don't need to do it. Someone else has done this. And our nursing staff said, I want to do the screening tool for the shift that I'm on. And I said, yeah, fine, we're going to do that. We know that that creates more screening tools, and my audit team are over there. I'm not going to look at my audit team because it creates them a lot of problems when they're doing their audits, unfortunately. But it is the right thing to do because it allows the staff to look at that patient when they change over the shift, and then they can ask the quick question, this was the plan. Is it enough? Do you want to change it? And that tied into some of our harms that we had. So we looked at harms that we'd had in the hospital, and they revolved around change of shift, where the plan wasn't updated, change of ward, where one ward thought something was done on one ward and it wasn't. So these were really important things that we did. And we listened to our nursing staff and we went with what they wanted. So that's what we put in. So you can't see on here all the writing, and that's okay. Really all you need to see are the colours. So this is my quality improvement data sheet. The green, yes, a screening tool has been completed, and the red is no, it's not. So in the first 2 weeks, we did the programme, we run the education, look at the data sheet, and we set where we expected that ward to be at the end of 2 weeks. And our projection was 30% at the end of 2 weeks. So we've got a lot more green, much less red, and we also reduced the number of trigger points. Now, we see this in some of our longer stay wards. In the short assessment areas, we don't see that at all. But in wards where they're there a little bit longer, where the patients are there, we saw that people were not deteriorating as much. And that, I believe, fundamentally, this is because we're picking up on things earlier at a lower score, and we were potentially stopping some deterioration. And then this was there last week. So that's where they finished. So third week, they were at 89%. And in their last week, they were at 92%. So they missed one trigger point from that. And that was the program that we've done. And every single ward has had that program. It has been an investment in time. It has been a longer journey because it was only me that was rolling out the program. But that's how it was. And we were always looking for a long-term solution that is embedded in the trust. And I feel that this is what we have done now. So this was just their examples of the data. So end of week 2, 78%. End of week 4, 89%. End of week 5, 92%. We also, as the wards come on, we have a whole data sheet for all of the wards within the trust. And we've got about 36 wards, I believe it is. And so they're all on here, broke up into the divisions, and green is above 90% of screening. Okay, so they're sepsis champions. When I move on to the next ward, they take over. And they do their monthly audits, and we show them how to do their monthly audits, and then they feed the results back in. And this is our track of where they've been. Bear in mind, keep going back to, we were 0 to 4% before the program. Okay? So we do monthly screening reviews, and we're red rated, RAG rated. So if the ward is in green, that's fantastic. If they're in amber, that's acceptable. If they're in red, the sepsis champion has to make a quick improvement plan to bring that ward back up. And these are some of the standout results that we've seen. So Gate 45A is our biggest respiratory ward, over 44 beds. 100% in their audit every month for 25-26, whole year. And their sample size is about 25 to 30 patients. So we show that we can do it. We also had Gate 21, our haematology ward, again 100% over the whole year. And then Gate 43, one of our adult wards, again another 100% every single month over the whole year. And then we also had Gate 32A, who was my example. They were over 100% over the whole year. And then the one I put on here was the orthopedic area. They dropped into the red. They put their quality improvement plan in, and then for the next 4 months and consecutively now continuing, they've been at 100%. Okay, now we're not saying all these patients have sepsis. We're not saying that at all, but they've all triggered the need for the screening tool, and the screening tool has been used, and we've used that screening tool as part of our escalation. So the conversation is something like this to the doctor. I've got a patient, their NEWS is 7, they've got these high risk parameters, I've completed the screening tool, it looks like they're a high risk for sepsis, I need you and what you want that doctor to do. I want you to come and review the patient. If you think it's sepsis, we'll initiate the sepsis pathway and the sepsis 6. And that's what our quality improvement program has been about. The thing that we've looked at on this slide is, in our monthly audit, we look at all of the patients who've triggered the need for screening from the registered nurse, and that's our performance for 24-25. So you can see there's 2 months in there where we've actually hit 100%. Every single patient in the sepsis audit in those 2 months who needed to be screened by the registered staff was screened by the registered staff. So that I believe that this shows that our culture is changing, and we have embedded the sepsis screening tool, and we move forward from that. This is how we present it. So we break it up into the risk stratifications when we do our audits, and we have the high risk, the moderate risk and the low risk. And we report back what our trust screening rate is within the individuals, and then as an overall percentage for the trust as well. And this is kind of where we are, kind of a bit on a little bit of a downward turn at this last couple of moments, but we've gone from 50% to between 70 and 80% is our antibiotics within time. We still know there's more work to do. We've identified the areas of where we need to make those changes, and then that's what we are working on.